some very nice stuff, largely focused on the right heart today. And to kind of kick that off, Andre Denault, who lives a bit to my north in Montreal, he's also had a cold, frigid winter. And you know, both of us are here finding Manchester actually kind of balmy. So with us in good spirits, I'll turn it over to Andre from the Montreal Heart Institute, who's going to give his section on echocardiography. Thank you.
Thank you very much. These are my disclosures. The black book over there will be available next fall, and several of the examples that you will see today, especially on the extracardiac complication of right heart dysfunction, will be in this. I'm also supported by the Montreal Heart Institute and the Kaufman Fund in Anesthesia and Critical Care. So basically my objectives are to basically review ventricular anatomy and also getting the most of your T views for right ventricular evaluation. So you all know that there's a significant mortality associated with RV failure. The good news is that it's coming down. It was in the 80s with the report in 1992 by Reichert, then in 53% in 1995. I was involved in an international trial in which we were trying to prevent RV failure. Unfortunately, it didn't work. But the mortality in these patients was 37%. And in the last trial, which is the Merynon trial, which we did in Canada, the mortality was 22%. So it's coming down, but it's still significant. So there's three ways you can evaluate cardiac right ventricular function: visual assessment, right ventricular pressure waveform, and this will be the topic of the next talk on Friday, and transoesophageal or transthoracic echocardiography. And in fact, in the operating room, we have the possibility of having all these three elements at the same time, so you can see them correlating. So the role of the echocardiographic right ventricular evaluation is first to evaluate the dimension of the right heart, to evaluate the systolic and the diastolic function, also to determine what's the etiology of RV failure. And something also we've been interested now for about 2 years is to look at the consequences of right ventricular failure with TE. So in terms of RV dimension, we've published a paper going much detail in ANA in 2001 with François Dade, who's a cardiologist in Stanford. But since we've published this paper, there's been some excellent papers on right ventricular function which have been published. And the most recent one was by Tan in the Journal of Thoracic and Cardiovascular Anesthesia, where they reviewed different views, which I won't go into detail. But in January 2015, Roberto Lang published the guidelines for quantification of the cardiac chambers, and there's a whole section just on right ventricular function. So these are now accepted American and European guidelines how to do the measurements, and I'll go over some of them. So the most useful view when you do transoesophageal echocardiography for the right ventricular function is the mid-esophageal four-chamber. And we often think the mid-esophageal four-chamber will be obtained at 0 degree, but in fact, there's a plus or minus 30 degree that you can use, and that's in relation with the coronal axis. So when you have normal right ventricular function, what you'll see is a smaller right ventricle. You'll see also the contraction, the area of contraction, which will be more than 35%. And something very useful that we look at is the motion of the tracheus annulus and also the position of the interatrial septum. So this is an example, and this is a nice four-chamber view, but what you can notice is the view is at 171 degree, and I just switched the left to the right. So what happened in some patients, the axis is not perfectly at 0 degree. Sometimes it can be a little counterclockwise, and sometimes it can be a little bit clockwise. So it can be minus 30 or plus 30 degree, and then by adjusting it, and if you have to go to minus 30, then you have to go to 170, and then you just switch, and then you can get a nice four-chamber view for your measurements. So one of the measurements, the guidelines recommend to do the following measurements. The first one is the right atrial size. There's the minor axis, and there's the major axis dimension that you will get. And also they recommend eventually to do volume of the right atrium, but only on one plane. And they recommend to use the sum of disc to have these measurements. The other elements that will be measured is the dimension of the right ventricle. And there's two areas where the measurements are recommended on a four-chamber view. One is the basal measurements, which is done at the basal 1/3 of the right ventricular inflow. And the second one is in the middle of the right ventricular inflow, the middle third of the right ventricular inflow. And normally these measurements are around 3 centimeters and a little bit lower at the RVD2. And also, in this measurement, you will measure the thickness of the right ventricular wall. And the thickness is, you need to zoom the right ventricular free wall. You do it exactly around the length of the anterior tricuspid valve leaflet, and you would exclude the papillary muscle and the fat. And normally, a right ventricular should be less than 5 millimeters. If it's more than this, then you're thinking of right ventricular hypertrophy. The next measurement that you will obtain will be from a mid-esophageal inflow-outflow view, which can be obtained from 40 degree to 60 degree. Again, it will depend on the patient's orientation. And from this measurement, what you will be able to get is a nice view of the right ventricular inflow and outflow tract, which is particularly useful for centered pathology, as we will see. So again, this is the right atrium, and you have the inflow and the outflow view. And from this view, there's 3 measurements that can be done. The one is the inflow measurements, which is perpendicular to the aortic valve, and the other one is just under the pulmonic valve. And you can also measure the pulmonary artery just on top of it. And these are the normal range which have been reported. In terms of function, what is recommended is to measure the right ventricular area, fractional area, which is the difference between the end diastolic minus the end systolic area. And the normal measurement should be more than 35%. If it's below than this, then the value, and that's the cutoff value to be considered as right ventricular systolic dysfunction. And also from this measurement, you can measure the, you can evaluate the displacement of the tricuspid annulus, and the displacement should be around 20, 25. The number, which is now the standard, is 17 millimeter. If it's below this, it's considered abnormal. The area also, they recommend to adjust it to the body size, because the area will be smaller in a kid compared to an adult. So it should ideally be divided by the body surface area. And you have the values here for men and women in diastole and in systole. For instance, we've just, there's going to be a paper published this year where we look at the change in right ventricular function after valvular surgery. And what we've noticed is the majority of patients after valvular surgery, there's a significant increase in the right ventricular and systolic area, which was significant, and was 7.9, around 8 centimeters square. So this is an example of a patient who has severe right ventricular dysfunction. You can see here the absence of any tricuspid annular motion, and you can rapidly appreciate, even without measurement, that the fractional area change is definitively below 35%. The next most useful view to evaluate right ventricular function is a transgastric view. With the transgastric view, you will look very carefully at the aspect of the interventricular septum. The interventricular septum should be concave on the left side. And by looking at the dimension of the right ventricle, the horizontal and the vertical dimension, you can determine if the patient has a volume overload. In that situation, what will happen is during diastole, the horizontal axis will become smaller than the vertical axis, and you'll have a D shape, only diastole. However, when it's during diastole and during systole, then you're talking about pressure overload. And that would happen, that would mean that during systole, the right ventricular systolic pressure would be probably equal or sometimes even higher than the right ventricular systolic pressure. So these are examples. This is an example of a patient who has a fluid overload with D shape in diastole. This is D shape in systole and diastole. This is pressure overload. This is another example of a kind of a mixed pattern, but there's maybe some curvature during systole. And this is another severe patient with severe pressure overload. There are also new measurements which are available for transthoracic echo, 3D measurements of the right ventricle. So far in the software, at least in Canada, I don't know, in the States, the software are not yet available for TEE. You have to do it offline. And also something which is now recommended in the guideline is to measure the strain of the right ventricle. The real advantage of the strain is that it's very sensitive to pick up change over time. For instance, it's particularly used in patients with chemotherapy because they can pick up myocardial dysfunction before they can see it clinically on 2D echocardiography. And this is an example of the strain of the right ventricle. And normally, when it's below 20% and as an absolute value, it's considered abnormal. The third role of echo when you have RV dysfunction is to determine what's the etiology. And something that we commonly see in the operating room, especially in open heart, is air embolism. And this is just an example where in this patient you could see air going right into the coronary artery. And you know exactly why this patient is developing RV dysfunction, often associated with inferior wall hypokinesia or akinesia. In some instance, you can have air embolism. This was a case during saphenoscopy. There was a breach in the vein, and then there was huge air embolism in this patient, and you can pick it up. However, if this happened, for instance, in the non-cardiac surgical setting, and you don't have TE, and then you put the TE just after it happens, this is what you might see. You won't see the hair, but you will see the consequence. And in this patient, you can see significant right ventricular dilatation and underfill left ventricle. And what can happen sometime on the left side is that they can get left ventricular outflow tract obstruction. And then if you use inotropes in these patients, you might even make them worse. And other elements that we've seen in lung transplantation is that sometimes just by looking at the waveform, you can have an idea of what's going on. This is a patient who was unstable after lung transplantation. What you can notice is their dampening of the pulmonary artery, which happens cyclically, followed by a reduction in the arterial pressure. And in fact, what was happening, this patient had a single transplantation on the right side, but the lung was too big. So every time it would inflate, it would create a tamponade, a mediastinal tamponade, or collapse of the right atrium. And in fact, the only way we could go through with this patient, we had to put him on ECMO, wait until the lung would become less edematous, and then we were able to wean him from bypass. This is another situation. The same thing can happen to the left. And this is a patient who was an organ donor and who was unstable when he was transferred to a hospital. And what you can notice, this is a kind of inflow-outflow view, which is through the interventricular septum. So you have the left, the right atrium. But what you can see here is you see collapse of the outflow tract. However, this was not during systole. In fact, this was during diastole. And what was happening in this patient, he was a trauma patient. He had chest tubes which were not functional. So basically, he had an anterior left pneumothorax, which in fact was compressing the outflow tract. So if you use the simulator just to show this, so if ever you have an anterior pneumothorax, the portion of the arch which will be compressed initially will be the outflow tract. So on the simulator, what you see in black here is the lingula. So in fact, when we just reposition the drain, this was the chest tube and the chest X-ray. Basically, the outflow tract obstruction just disappears. So it was an external compression of the outflow tract. Finally, one of the elements that we're very much interested is to see the consequences of RV failure, and we'll discuss this in more detail on Friday. But with ultrasound, there's 2 organs that you can evaluate at the bedside to see what's the consequence of if you have a severe RV dysfunction. One is the kidney, and the other one is the splanchnic circulation. So as you know, you can evaluate TEE. You can evaluate the kidney function with TEE. Once you are in the stomach, you just turn to the left at 90 degrees, and then you go from the spleen to the kidney. So when you have a nice view of the kidney, it's possible to evaluate renal perfusion. And if you just put the Doppler signal on the interlobar artery, this is the type of signal you will get. It's a similar signal that you get for intracranial arteries, the same signal you get also for coronary arteries. But basically, you have a systolic signal and you have a diastolic signal. And the maximal velocity of the diastolic signal should be at least 30% of the systolic signal. And that's called the resistance index. So what you see when you have right heart failure and even hypervolemia is that as your right atrial pressure goes up, you'll lose progressively your diastolic signal and you'll stop peeing. And as you improve your renal function, you'll see completely the opposite. And the renal function will improve. And it's possible to monitor this intraoperatively. The other element that you can also monitor, and I learned this from a gastroenterologist who does the TE of the abdomen on a regular basis, is that you can also look at the other abdominal organ. And as you move down, as you can see this is the celiac trunk. You see the kidney on the left. You see the spleen. But one which is very interesting, and especially in right heart failure, is the splenic vein. So this is the pancreas, and you have the splenic vein. This is the aorta, and this is the mesenteric artery. And this is what it looks like with TEE. So again, you have the pancreas, you have the splenic vein, the aorta, and you have the mesenteric artery. So a splenic vein, a normal splenic vein, and a portal vein is a laminar flow. There's no pulsatility. And when it becomes pulsatile, there's only one cause. there's only one cause. It's because the venous pressure are so high, they are transmitted from the heart to the splenic region. And it's typical of right heart failure, tricuspid regurgitation, and also hypervolemia. So this is an example of a patient who's much more unstable. Look, if you look at this patient, the mean arterial pressure was 62, the PA pressure was 22. And in this patient, the mean arterial pressure was 34, but the right atrial pressure was 22. And what you have here is not only pulsatility, it's flow reversal. Okay? So that means this patient is in full splanchnic congestion. And if you want to confirm it in other methods, and this is what we will discuss on Friday, the first patient has normal right ventricular pressure waveform, and this patient has a square root sign because the diastolic function is significantly abnormal. So in summary, right ventricular failure is still the cause, number one cause of mortality in cardiac surgery. There are guidelines used to quantify right ventricular function. The role of echocardiography is to determine not only the function, the dimension, but also the etiology and the extracardiac consequences. Thank you for your attention.